teeth removal, then regular combined intrusion and retrusion full system on the upper, and only lower anterior test. We can close all the spaces. 22 months, not very fast. And I think the facial profile change looks good, but the patient was not satisfied. And she asked for counterclockwise rotation of the mandible. I said, what? Counterclockwise rotation of mandible. She said she saw it on the internet. She said we close all the spaces to reduce the protrusion, but what we missed, maybe counterclockwise rotation of mandible. This surprised me a little bit. And I said, if you think so, maybe we take a record to check. Actually, we got some counterclockwise rotation of mandible. You can see the chin projection improve a little bit, and the overall facial profile, I think it is good. And superposition showed pretty normal response. However, she asked more retraction. She asked for counterclockwise rotation. I add another mid-palatal test for total arch digitalization of the upper dentition. So after 9 months, I believe there will be some more counterclockwise rotation of mandible. Guess what? She started to complain the incisor far too back. You need to know, this is a camouflage treatment to mimic the orthodontic surgery. There is no way. We are not magicians. But of course, you know, it's very difficult to communicate with this kind of patient. So she complained the upper incisor too upright. We need to apply the palatal root torque to regain the torque. And she said it is too back. So I need to use the mid-palatal test, fabricate MTAD protractor to protract the upper dentition. Of course, I need to check. I need to show her. You see, it come forward. And if you want to keep the treatment effect, you will not want to protract it all the way back to the original, right? So finally, we will settle like this. The occlusion, no problem. The facial profile, I think it is good. I think it is good. The tooth show is no problem. And here is the before and after. The cyclometric superposition showed, yes, active vertical control, counterclockwise rotation. But she complained of the upper incisor too far back. So we need to protract. That is why I always suggest our colleagues, please do not use this kind of successful cases. Which is not routine. We can make every effort to help the patient, but I do not suggest to use this kind of successful experience like a promotion. Otherwise, it may be a little bit misleading. So here, I like to show you some other cases to I like to show you the last case because it's a case that I will show to this kind of patient. As for this lady, actually her pre-treatment condition was pretty bad. And she was an open bite. But here is a badly decayed lower left, first molar. So we decided to remove upper 4 and lower 6 plus upper wisdom teeth to close all the spaces for maximal retraction. So no problem, we can retract all the anterior teeth to maximize the profile improvement with the combined intrusion and retraction forces on both arches. And here is some progress. You can see the facial profile improvement. She was happy. She was very happy. But when we close all the spaces and we finish like this, look amazing. But when I try to make the superposition, I cannot fix the nose because she got the rhinoplasty. You see, when she got some improvement, she will want more. It's good, it's good. So she got the rhinoplasty. That's why, in addition to sagittal and the vertical improvement with the orthodontic tooth movement, you may still enhance your facial profile with the rhinoplasty, which makes her a beautiful face. During the follow-up, she enjoyed the treatment effect of the rhinoplasty. She got another procedure of the chin augmentation. So it is good. You know, this kind of interaction is good. You can show your patient these slides. What do you want? If you want this treatment effect, orthodontic treatment. If you like this, you may need one more rhinoplasty. But if you are not satisfied, you may further consider the genioplasty, the chin augmentation, just like a menu, right? Sometimes we need to communicate with our patient like this. And to conclude my talk today, I will say, if we try to treat the surgical cases without surgery, I will say the extraradicular test might be the most important part because it provides you a reliable anchorage to control your tooth movement, and you need to master the three-dimensional control of tooth movement, as these cases are not very typical, not regular orthodontic treatment. So we need to have this concept of sagittal, vertical, and transverse. Otherwise, if you only focus on one dimension, you will not make it. But I want to say, every one of us, we need to respect the boundaries of tooth movement because there must be boundaries. But some doctors worry about the scope. We can move the tooth, but I think yes, we need to respect. We need to evaluate. We need to look at the response carefully with the maybe with CBCT. Besides, after so much massive amount of tooth movement, there might be some periodontal consequence. Initially, the patient complained about the exoastosis after massive amount of retraction. But of course, if we know it is a routine, we can inform the patient in advance and tell them it is a possibility, and it is possible we need to send you to the periodontist for periodontal surgery afterwards. Sometimes it is not necessary. It's good. but we need to let them know in advance. And one thing I like to mention, some patient, they do not want to have periodontal surgery, but during the follow-up, we can see it disappeared. It's about the metabolism, the bone metabolism. For one case, not only one case, for several cases, it's related with the pregnancy. After she delivered a baby, the bone disappeared. And another one is about hyperthyroidism. So you cannot see because the metabolism rate is pretty good. So I think the most important part, I would say the patient communication. And for the retraction of the anterior teeth, I use posterior test. But I prefer use the infrazygomatic crest because it's outside the roots. And for lower, I use the buccal shelf test. But I will say they are not true extra radical. You need to check. You know, when I look into my success rate of tests, the most highest rate lies in plateau tests. That's why there are so many doctors who prefer to use plateau tests. No wonder. I also like to use the plateau test. But using the plateau test might be necessary to fabricate some kind of appliance, just like you see. So, of course, buccal test easier to use. But what I try to say, the second place, where is the second place? For me, the second place goes to anterior test. Because the anterior test, subapical anterior test, they are true extra radical. Or I should say extra alveolar. Because there are no structure at all. Anterior part, the symphysis, the anterior subapical, the plateau, they are true extra alveolar. For ICC, for buccal shelf test, yeah, more like extra alveolar, but not really. Sometimes the proximity may still lead to some failure. And for anterior test, I prefer to use subapical test by myself. Of course, any kind of test, if you can apply the force without the mobility, it's okay. And I also want to emphasize the effect of the toe control. You see, the anterior test, but the anterior teeth were done after retraction. If it loses some torque, then there is no way for lower incisor, for lower jaw to come forward because there is incisor interference. If you can torque them out, then there is a possibility for the lower jaw to rotate forward. So I like to call your attention on the upper incisor torque. However, it's the most important part. You need to know you are trying the extreme sports. That's why I suggest you not to treat too many challenging cases without surgery. Of course, you can try, but not too many. You have seen a lot of these. No place to place the roots. Anatomy, right? Anatomy. We need to respect. And I'd like to thank all my colleagues working together with me to see my patients together, and we work together as a team. I think nowadays the interdisciplinary approach is very important to satisfy the patient's needs. So try to use the test and interdisciplinary treatment to maximize the orthodontic potentials. Thank you very much for your time.